Good evening, everybody.
Good evening, madam.
Good evening.
Good
Good
evening. Initially, I was confused whether it is today or Friday. Now I got the essence from Manish's. Manish briefed me about everything.
Good evening, Manish sir. Good evening, Jigar bhai.
Good evening.
Hello.
Hi everybody, Dr. Jafri sir.
Good evening, sir.
Good evening, sir.
Hi, good evening.
Hi, good evening. Vinay here from CMC.
Good evening, sir.
Good evening.
Hi.
Hello, Vinay sir.
Hi.
Good
Hi,
evening,
ma'am.
everybody.
Good
Hi,
evening.
ma'am.
Good evening, respected seniors. Good evening, Arpita madam.
Good evening, Jigar. Good
Good
evening.
evening, madam.
So, Saurabh, Arpita madam is not senior, is it?
Ma'am, she's here, ma'am. Visible, ma'am.
That's why we
You
are all
said
visible.
seniors and
I'm not.
Arpita madam.
He
Yeah.
separately called.
Urmila.
Hmm.
Yes, I can see Urmila.
Ma'am, you are visible, ma'am. Good evening, ma'am.
Good evening, madam.
I'm visible. Okay.
Yes, ma'am.
So once Manish welcomes all, I will briefly talk about the theme of these drugs in immunosuppression. Manish
Yes, ma'am.
intimated
Yeah, ma'am.
me to.
I'll
Yes.
start sharp at 6:30. At
Okay.
6:20, right?
Okay.
Just.
Shall we start, sir?
Yeah.
6:30 now. Please.
Good evening, everyone. On behalf of ISOT, I would like to welcome you all for our this new webinar series, Drugs in Transplantation. I would like to thank all our speakers, panelists, moderator for taking their time out for this new initiative. I would like to request President Madam Dr. Arpita Lahiri to please welcome everyone and brief all ISOT members regarding the new concept.
A very hearty welcome to all who has joined as speakers, panelists, and also my beloved students who have joined as audience. We know that using immunosuppression is like walking on a tight rope. One way you need to balance the dose to satisfy the body's need, not to reject. The other way you need to prevent the infection, which in Indian scenario is a common cause of losing the patient with functioning graft. So, keeping this in mind, it's good that we discuss about these drugs, their concentrations, how we can really look at their optimum dose, which will prevent, which will not, which will prevent rejection, but will not invite infection. So that journey starts today, and I think it will continue for few days in August. Every second or third day, we will be picking up one drug and discuss it in detail. So that we know the various ways to use them in combination and in isolation. Thank you, Manish, for taking this initiative. Shaurabh, please start the proceedings and invite others to join.
Thank you, ma'am. Good evening, everyone. Warm welcome to everyone for joining us for this ISOT EduConnect session under Transplant Drug Update Series. We are thrilled to have an excellent panel of experts today to walk us through clinical nuances and latest updates in transplant pharmacology. So for the first session, we have Arpita Ray Chaudhary, ma'am, Dr. Umapati Hegde, sir. Sir is Vice Chairman, Mulji Bhai Patel Hospital, Nadia. You are welcome, sir. And Dr. Palvi Prasad, ma'am. Ma'am is Professor in Nephropathology at SGPGI, Lucknow. Welcome, ma'am. For the second session, we will have Dr. Devdutt Chafekar, sir, who is Senior Consultant Nephrology at Nasik. Dr. Jigar Srimali, sir, who is Senior Consultant Nephrology at Ahmedabad. Dr. Subho Banerjee, sir, who is Professor Nephrology at IKDRC Ahmedabad. For the third session, we have Dr. Urmila Anand, ma'am, who is Professor and Head of Nephrology at Amrita Hospital, Faridabad. Dr. Binoy George David, sir, who is Professor and Head Nephrology at CMC Vellore. And Dr. Lavdeep Dogra, who is Nephrologist at Jaipur. Let's dive into today's focused discussion, and we look forward to an engaging, evidence-based and practical learning experience. So the first talk is on pharmacodynamics and GI toxicity of MMF. So for that, over to you, Dr. Umapati Hegde, sir.
Thank you. Thank you, Dr. Saurabh, Manish, Arpita madam, and the ISOT for giving this opportunity. So pharmacodynamics and GI toxicity. GI toxicity is one of the most important, and MMF was first discovered in 1986. And at 1960, it was used as a therapeutic agent. And in a psoriasis, it came in 1970. Later on, it came into as an immunosuppressive agent. The problem is all immunosuppressions, we have to be very careful about the CV and the infection prophylaxis to reduce the rate of not only the rejection episodes, but also infection so that they live longer. Approximately 20% of the patients, they return to dialysis after 5 years and 50% after 50 years. So the significant number of people they will require drugs or toxicity remains an important morbidity and mortality in addition to the cardiovascular risk and a malignancy. We all know that the MMF, it peaks and it's around 0.7 to 1 or 1.5 hours after taking it. And it slowly, it goes down by 12 hours. And it's a T-half is at which it has lost its half the maximum concentration, and C0 is where the before the next dose. Why we have to do monitoring? Because the immunosuppression is an important, and it reduces, it varies, and even with a fixed dose combination, it may vary from low to even up to 10-fold increase. And it may range up to 100 milligram per hour for those things. So it may usually what we require is 30 to 45. And this variation, it causes more of GI toxicity and also hematological and other toxicities. This is one of the study where they have shown that even 1.5 gram a day, they were able to achieve significantly 31 at the AOC 0 to 12 of milligram per liter. And so at 24 weeks, they were able to use the same concentration. They were able to get even at 1 gram per day, 1.5 gram per day also. So in our series, where we did in 77 patients, we had 57% remained less at the end of 1 month, and we were able to achieve even with 1.5 gram able dose. The effectiveness it starts when whether it is toxic dose. So it has to be effective dose should be in a narrow range. So it has to be within 30 or 40 or not beyond 60. So if it is above or below, both are not effective. So because it causes more of rejections, and if it is higher, it causes more toxicity. So here the exposure is very high. Even though it starts at the lower, the higher levels are achieved. So those are toxic. What are the factors which change the physiology? Is the renal function, the concomitant immunosuppression, the GI tract, and the albumin level, proteinuria, all this matters. Even the normal, what we are concerned is an unbound or a free MPA, which causes more toxicity. When there is hypoalbuminemia, the total, the unbound or the free remains the same, and the total reduces. When the GFR reduces, there is an increase in the unbound fraction. So whenever there is a renal function, you may have to slightly reduce the dose. Otherwise, the unbound fraction of the free MPA, it increases, it creates a problem. Whenever the GFR reduced without inhibited in a EPNT, and there is both, there is increase in the total and also the unbound concentration, which also creates a problem. So to know what should be the target, the different RCTs which we have done earlier, and the low was shown to have 16 and the median was 32 and the high was 60. And they've shown that the biopsy proven rejection occurred more frequently in 25%, 19 and 15. So those were high, they are very, very minimal, and it was moderate of 14.9, and it is high when the level was very, very low. So the patients with requiring merolimab or an ATG was numerically higher when the level was very low. So logistically, they've shown that it has to be maintained, and the biopsy-proven rejection can be reduced by 50% and 75 and 90%. And when it is around 15, 25, and 40, so 40, it reduces almost 90% of the biopsy-proven rejections. So, but the monitoring is tedious. It is not available everywhere, and it is not an easy task. And another trial, RCT, which shows that after a trial in 137 patients, they used the fixed dose and the targeted level. They were in the first 3 months, usually the rejections will happen. The 70% were associated when the MPA level was less than 30. So if you have an MPA level at 30 to 45, your rejections episodes significantly reduced, and also you can have a better longevity. Day 14. So after the adjustment, they also show that there are significant people, 68% of people were able to have a significant level. MPA dose of 2 gram was less than 2 gram was seen 6% at 1 month, and 26% at 3 months, and 48% at 6 months. So as the time advances, the requirement of the MPA or achievement of the level may increase. So you may have to be very careful, and the adjustment has to be done, or the level may have to be seen, and the patient get a rejection, or when you reduce the dose significantly. The OPERA, which also, it's another trial which significantly shows even earlier to achieve a level, first 10 days, they were given 3 grams, and then the targeted level was seen. The primary biopsy proven outcome at 3 months was the target, but most of the patients had a problem. They did not tolerate well, but the rejection episodes were less. We all know that we take an MPA, and in the intestine by the carboxyesterases gets lysed, and the MPA is absorbed by the ABCB1 and also ABCC2 channel. It goes into the blood and it enters the lymphocytes, where it inhibits the IMPDH1 and 2 and reduces the purine synthesis. So in the blood, again, it goes back into the liver, where it is metabolized into MPAG and MPAG. So MPA acyl glucuronide, it is also, and then by the ABCC2, and it goes into the bile, enterohepatic circulation, it happens, and it may be lysed by the bacteria, and it releases the MPA again and gets reabsorbed. The animal models have shown that the toxicity may lead to ulceration, erosion, and the necrosis of the stomach and the small and the large intestines. So the registration studies of MPA and EPMPS have confirmed diarrhea, vomiting, and GI reflux may be an important cause. And most of these are, they are dose dependent, but again, it may not completely, the serum level may not correlate with the GI toxicity. So The problem then there was whether it was a systemic toxicity or local toxicity. European multicentric trial of 325 patients, those who are receiving cyclosporine, corticosteroids, and GI, they have reported 40% also with a placebo, and the MPA GI side effects were almost around 45 to 80. So in transplant patients, most of the patients have GI side effect because of the other drugs also, and MMF adds on to it. So what is the difference what we have between the MPA and the EC-MPS? The EC-MPS dissolves at 5.5 to 6 pH, allowing the delayed absorption. The peak is slower. It comes at around 2 to 2.5 as compared to 0.75 to 1 hour with an MMF, indicating slow absorption, and possibly the events may be reduced with a slower peak. What is the problem if you have to discontinue, because most of the people may have GI toxicity? Then we can reduce the level and we can monitor it. But the problem is 20% of those patients who are receiving MMF will require dose reduction due to GI toxicity, which is significant. And so it may have problems. And GI loss, the graft loss is very, very significant. So if there is no GI side effect and the MMF is continued, at the end of 4 years, if you see only 12.9% lose the graft. If there is a GI and MMF are continued with the low dose, 17%, and no GI side effect and the MMF discontinued, it's almost on 17. But if you have GI side effect and MMF is discontinued, almost 29% they lose the graft at the end of 4 years. So this was the UNOS data, which shows in 16,400 patients who are taking MMF, which shown that the MMF discontinuation because of the GI side effect significantly affects the graft survival. What are the etiologies about the MMF or an MPA-related gastrointestinal toxicity? It may be a direct gut toxicity of the mofetal ester. It's basically hydroxyethyl morphine, which is the basic thing. So it is just esterized to increase the absorption, because the absorption may be poor when you use others. Anti-proliferative effect of systemic or the local MPA, leading to MPJ inhibition, and the combination with calcineurin toxicity, especially tacrolimus, opportunistic infections, modulation in the local immune system, and the toxicity of acyl mycophylic acid, acyl acid glucuronides. These are the possible mechanisms. So ester it's a MMF is a mofetal. It's 2-hydroxyethyl morphine. It's an ester of an MPA. So its goal is that it has to improve the MPA absorption. There is a limited evidence where this MPA, it has a local irritative effect based on the findings that it causes severe irritation in the rapid model and the local toxicity. So possibly it's an animal model has significantly shown and shown to have erosions also. The side effects may be dosing and the potential therapeutic. Basically, GI side effects happens in almost 40 to 50%. It leads to reduction. If there is a 50% reduction in the dose, there is twofold increase in the risk of rejection. If it is discontinued, then it is a problem. So EC-MPS may be a practical option. And the 2 open label studies have shown that the conversion from MMF to MPS, it may improve the level and the GI side effects also. So this is the chart which shows that if MPA dose, no dose reduction, they have a good percentage. They have a rejection-free survival. Otherwise, 50% dose reduction, they're almost around 32% have rejections as compared to only 15 to 20% with this. Changing from EC-MPS, whether it will handle, it was the study by the Korean group, and they had a questionnaire about the GI symptoms. If the score is more than 2, they converted into EC-MPS. If it is less than 2, they continued MMF, and they saw. So basically, gastrointestinal symptom scoring, GIS scoring was done. Patients, they had physicians completed the overall treatment, and the MPS converted patients had a worse GIS outcome and GI score as compared to the baseline. So even though if they have a baseline score is lower, they may increase with time, but the EC-MPS, they improved. There's another study where they have compared, showing that the they have an intolerance is only around 29%, and the calculated rejection was 20%, as compared to the MMF, the intolerance 44% and 24% rejection, which mounts to almost around 120,000 US dollar morbidity or increased financial burden on these patients, which concluded that the ECMPS treatment is cost-saving alternative to MMF in those who have GI intolerance, and it may help, and it is cost-saving also. Whether the systemic or the local, which is an important factor for all these side effects, is because the systemic exposure also is very, very important. It's a determinant factor, but usually the non-lymphoid cells, they utilize the salvage pathway to synthesize purine. But in those who have rapidly progressive cells, especially the intestine, they may have a significant sensitivity, and they develop ulcerations and also the toxicity and erosions and erythema because of the IMPDS suppression. So systemic exposure thus restrict the ability of the intestinal epithelial cells to maintain the normal barrier, and also to decrease their capacity to recover from the damage which has happened because of the IMPDS inhibition. Oral and intravenous have shown to have a similar GI toxicity. So possibly it's the local and the systemic both play an important role. And the reports show that superior tolerability with IV MMF compared to the oral. And so this we have to, it's both are important, and the level and even the enterohepatic circulation and release of MPA after the bacterial effect is also significant. The concomitant immunosuppression is important because cyclosporin, it inhibits the portohepatic reflux, and the cyclosporin has a pre-systemic MPA metabolism and also the MPA and the side effects. So either staggering the administration by around 2 agents by around 1 to 2 hours, it may reduce the symptoms also. The dosing immediate release formulations of MPA therapy, it may be changed from 2 times daily to 3 to 4 times, so that their peak effect also reduces. They may also reduce the toxicity. But again, we don't have large studies to show that using 4 times, is there any effect. So the MPA-AG enterohepatic recirculation is not happening with cyclosporin, but happens with tacrolimus. So the MPA levels significantly increase, and this is also increases the toxicity. The emerging role of acyl glucuronide. So basically, whenever the MPA, and then it is by the glucuronide transferate, it gets converted to MPAG and acyl MPAG. Acyl MPAG is toxic, it's metabolized, and it is discovered found to have present significantly in plasma concentrations in renal transplant recipient receiving MPA. Acyl MPAG, it has the effect that it inhibits the IMPDH and also exerts the toxicity due to its capacity to acting on the proteins. So the UDP glucuronide transferases are also producing the metabolites, and its capacity in the enterohepatic circulations, it's significantly. So MPA from the second source, it is metabolized locally to MPAG to an acyl MPAG, which also recirculation process, it causes significant problem. It acts on the proximal GI tract, stomach, duodenal, and the higher concentrations where there is glucuronide transferase activity is there. So it significantly affects the enterocytes. So if you see in this chart, if you see that the EMPS has a lesser diarrheal scores as compared to the MMF, so it is tolerated very well. If you do an endoscopy, some of the patients may have a normal endoscopy. 47% of the patients may have normal, and the diagnosis is made by the mucosal biopsy. If you don't do a biopsy, you may not see the infiltration. So even though the mucosa looks good, the biopsy is mandatory. All these have an abnormal endoscopic findings, have the sparing the rectum. So the rectal sparing is an important clue that it is due to MMF. And comparing the findings, the presence of erythema is very, very significant. And the erosions and ulcers are significantly associated with the MMF when they have more symptoms of diarrhea, and it will lead to MMF colitis. Pathology, what we see is crypt apoptosis. So basically, the apoptosis will be seen, crypt apoptosis, and few apoptotic microabscesses are seen. Increased eosinophils are present in the lamina propria. Neutrophilic infiltration will be there in the lamina propria, and cryptitis and cryptabscesses. Lack of lamina propria endocrine cell aggregates, and the pseudosis and the metaplasia is also seen. And similar to Crohn's and also the ischemic colitis, they may have a patchy infiltration and lymphoid hyperplasia, and loss of architecture is seen in pathologically. So it usually the rectal sparing is important, and endoscopically you can see the range from erythema, erosion, and the ulcers. And it is similar to the IBD, or it may be an ischemic features in 6% of patients in those who have colitis. So it is important if you see. Most of the patients will diarrhea, will have to rule out infections post-transplant, especially CMV, and we may have to have the level if possible, and the bacterial culture and the PCR and the CMV has to be ruled out. And other viruses, importantly, what we have, normovirus and adenovirus, astro, rotavirus, sapovirus has to be ruled out. If there is associated fever, possibly it's a bacterial origin, antibacterial agent should be used. If norovirus, if it is the reduction in the therapy, CMV, ganciclovir, if there is nothing, then the dose reduction has to be done after ruling out these things of an MMF. So if there is no infectious cause, and then we have to reduce, we'll have to see the FK506 tacrolimus, which that also stimulates and causes loose motions, and the tacro levels has to be adjusted because the loose motion also increases the level. The MMF has to be stepwise, it has to be reduced, and if it is further progresses and there is no other cause, you may have to change it to azathioprine or everolimus. If there is no significant proteinuria, and if you had rejections, you can change it to everolimus also. If there is a good, otherwise you can reduce it or change it to azathioprine. This is one of the study of 544 patients who have treatment as mentioned. They were not mentioned in 73. So 487 patients, among them MMFs continued in 105, 21% of patients. They had 23% of them have a spontaneous resolution, but 17% had persistent diarrhea, which required further intervention. Switch to EGMPS. Almost those patients who have 95% they responded, and 7% have not responded, they required further. And MMF discontinued, almost to 98% responded. And so you have to have multiple approaches. First is reduction of the dosage, change from MPS to others so that the patients do better. The vancomycin is shown to reduce or prevent the GI toxicity of mycophenolate. So it reduces the bacterial flora, which reduces the enterohepatic circulation. So it reduces the free drug availability in the enterocytes. So it is significantly, it's shown that reduction in the cecal and the colon tissue architecture by the mucosal and submucosal erosions, it has reduced, and loss of intestinal crypt and the extensive inflammation also is significantly reduced. Another is it's prevented is MMF is it also reduced the shortening of the colon. Weight loss also significantly reduced with vancomycin use. So shows that the mycophenolic acid, it significantly reduces the hydroxyproline absorption significantly, pyridoxine absorption, ascorbic acid, everything is significantly so normalized after giving vancomycin. So another inhibition of the MPA hydrolysis by the amoxicillin, it is again, it's an animal model which shows that it significantly reduces in the mice model that the availability and the effect of MMF toxicity significantly reduces. To summarize, MMF level is variable. We may have to have a monitoring if it is possible, and it may vary from less than 30 to more than 100 milligram per hour, and we require an adequate level to reduce the rejections, but increased level causes toxicity. There are various causes for GI disturbances or diarrhea. MMF is one of them. After ruling out the cause of infectious, MMF is essential for GI side effects. Reducing the dose, changing to MPA, ECMPA, or changing it to azathioprine, mTOR may resolve the side effects. Needs monitoring of renal function, and increased chance of rejections are there when you are reducing the dose. So you have to be careful. More frequent monitoring is required. Thank you very much.
Yeah, thank you very much, sir, for setting the stage with such a comprehensive and clinically relevant overview. An excellent start to today's session. So now a panel discussion. First question for Arpita Ray Chaudhary, ma'am. Ma'am, what is the clinical relevance of intrahepatic recirculation of mycophenolic acid, as Hegde sir has already discussed, and how does it affect drug level variability in Indian patients?
Yeah. So cyclosporin has almost disappeared from our immunosuppression platter unless there are some specific situations where we do use cyclosporin MMF. So when you use tacrolimus MMF, we need to remember that the net immunosuppression may go higher because of more free drug availability from MMF. So what happens there that it may invite infection, and diarrhea is a very common cause where you can uh, get this intolerance to MMF versus infection related diarrhea. So what from our work we have showcased that routine stool examination and stool that delay the result availability of the result of the infectious agents, and when we do send early stool PCR, then it's a costly test, but it is important adjunct because we can easily diagnose the infectious cause, and the jugglery with the drug dose and the antibiotics or antivirals are not there. We can hit the specific cause. So remembering the innate immunosuppression, substituting MMF in a right perspective with azathioprine or everolimus, tacro-evero in balanced dose in late part can address the immunosuppression issue, and that may help those who are intolerant to azathioprine too. They can continue on tacrolimus everolimus steroid also in the later part, not in the early part. In the early part I would never suggest, because DNDSA suppression is best with this TAC MMF combination. So early part, balancing the MMF and targeting the proper area under curve level. If the area under curve can be made available, the 30 to 45 golden means, not going above 60. So that's also a very good adjunct. That would be a very good adjunct because only few centers are doing it because of logistic issues. These two tests, tool PCR and this AUC level availability, can more precisely define the dose, the enterohepatic circulation related issues when MMF is used in combination with tacrolimus.
Thank you, ma'am, for the nuanced explanation. Truly, the unpredictability in Indian patients because of genetic and dietary factors, they deserve more attention in our day-to-day practice. So, second question is for Dr. Pallavi, ma'am. Ma'am, what are the characteristic histological patterns of GI toxicity, which is associated with MMF, and what histological features suggest reversible versus irreversible damage?
Okay, a very good evening. Firstly, thank you a lot, Dr. Umapati sir, for the nice and illustrative talk. And yes, Dr. Saurabh, coming to your question, like we have certain clues on a colon biopsy which can indicate that what are the features of MMF toxicity. Like our challenge as a pathologist is to differentiate the MMF toxicity from either GVHD or CMV colitis, or it can be an IBD also in a transplant setting. So what we look for is, firstly, the important clue is crypt apoptosis. So crypt apoptosis, we find the apoptosis in the enterocytes. However, that is very focal and patchy. And this is a feature which is more pronounced and more diffuse in GVHD. So first thing is this. Then second, if you look at the overall architecture, that may show mild to moderate degree of crypt distortion. That distortion is never diffuse, like that is expected to be diffuse in cases of IBD like Crohn's or ulcerative colitis. Then the inflammation, it can be either mild to moderate degree in a biopsy, of course, like I'm just comparing all the three entities, because like GVHD, that will not show any degree of inflammation, that will have minimal inflammation. That can be seen in our case of toxicity. Also, then, because it is a drug induced injury, so the expected finding will be a predominance or an increased number of eosinophils. So there will be a striking increase in the number of eosinophils in the lamina propria. And that, of course, if we compare it with this IBD, that will have, depending on the stage, more of lymphocytes or plasma cells. And if it is an acute stage, it can have more of neutrophils. And also then we can have crib distortion I've mentioned, that can be of either mild degree. And then you asked about the findings of reversible and irreversible damage. So of course, the earlier or milder the changes, the higher are the chances for it to be reversible. So if we have just incipient changes, like we have mild degree of inflammation and mild degree, the surface ulceration has just started, so that change is reversible provided the offending drug has been removed. So at least in 2 to 4 weeks, it has been mentioned that the histological findings may reverse. But if the findings have moved more towards chronicity, or they have moved more towards the severe stages, like the whole of the epithelium is ulcerated, or the lamina propria is replaced by fibrosis, then that those changes are unlikely to be reversed. So that will constitute your irreversible causes.
Thank you, ma'am, for this excellent overview of histological spectrum and its clinical implications. So our next talk is on managing leukopenia, infections, and pregnancy considerations.
Can I ask
over
a question
to you.
here?
Yes, sir.
I just have a
Sir.
question that we have seen some patients who develop this GI toxicity very late in the course of transplant. Almost 5 to 6 years after transplant, the patient is doing very well. And at the end of 5 to 6 years, we found that there was diarrhea. All investigations were done, and the only thing which helped was to change to azathioprine because the immunological profile was acceptable. So does anyone have any explanation for this late onset diarrhea which responded to change of mycophenolate to azathioprine?
So usually I also shown that the degree of absorption also varies with time. So the degree absorption also slowly it increases. So even we have seen after 5 years of therapy of MMF, even 750 milligram or 500 and 750, we saw weight losses and GI disturbances, and we also changed to azathioprine. In one of the studies, they have shown that at 6 months, only 6% of the patients were less than 2 gram. 30% and 60% of the patients at the end of 2 years were less than 2 grams. So the dose requirement to achieve, even though it is in the target level, with time, the requirement may reduce. Possibly, I think each will vary, but most of the patients, because the ongoing activity or the suppression with increasing proliferation of the enterocytes, some people are more prone to it.
Is it recommended to do the AUC at that time?
So ideally, it came as there was nothing. But again, now the facilities are available, you can do it and see. But most of the times, the systemic level, and it may not completely correlate.
Thank you.
Thank you, sir. Over to you, Jigar Srimali, sir.
Okay, so today we are going to have a second part of this. I think the PowerPoint is shared already.
Yes, sir. Yes, sir. It's visible, sir.
So my role would be to discuss today is related to leukopenia, infection, and pregnancy with MMF. So let's discuss about the leukopenia first. On an average, around 20 to 45% of the solid organ transplant recipient generally having reporting of leukopenia. That leukopenia generally to be there on first initial part of the transplantation, generally first 3 months, but it can occur anytime after the transplantation. So what are the risk factor that we need to keep in mind whenever there is leukopenia in post-transplant patient? Is obviously it is a dose related as far as MMF part is concerned. Again, with tacrolimus, it is more to have leukopenia compared to cyclosporin, as Hegde sir explained. Again, low body weight, impaired renal function, have level and clearance issue. Elderly patient would have more susceptibility, and simultaneous, if any infection or medication that lead to bone marrow suppression, that then it adds on. Now, for the management part, we need to see whether the severity of the leukopenia. If the leukopenia is just mild enough with the count around 3000 to 4000, we need to be watchful enough so that for any active infection, we need to rule out CMV, sepsis, and other viral etiology. And if uh, it is persistent, then and then we need to reduce the MR. For moderate leukopenia with count around 2000 to 3000, we need to again rule out first the infection. Ideally, we should reduce the MF dose to around 50%. And we need to consider for stopping other myelosuppressive drug like valganciclovir. And if needed in high-risk patient and persistent leukopenia or it's progressive, we can add GCSF. For severe leukopenia, where count would be less than 2000 or ANC will be less than 1000, we need to withhold the MF first and need to treat the infection aggressively. We can switch over later to azathioprine and again GCSF can be used with high-risk patient. We know the evaluation will be there with CBC, differential count, retic count, need to rule out the viral part like CMV, EBV, parvovirus B19, BK virus. Generally, rarely bone marrow biopsy is needed when the pancytopenia is persistent and we don't find any other causes. As Hegde sir explained related to MAF trough level or AUC level that we can see. So, as we discussed, there are no proper guidelines. Institute-specific protocols are there. In KDIGO, it is mentioned only that the MF dose modification in leukopenia is appropriate, but we need to avoid the abrupt discontinuation unless it is severe, because otherwise it will lead to rejection. So as we discussed, we can see the mild, moderate, or severe leukopenia, and accordingly we can decide further. Now we have reduced or discontinued the MF at one state, but is there anything or when we should reintroduce the molecule? For that, we need to see how the recovery is there. Once the recovery is there, we can start with the lower dosage. We need to monitor the complete blood count every 3 to 5 days as per the need for first 2 weeks, and then the further increment that will depend on the leukocyte response will be there. So this was about leukopenia. Now, if the patient is having infection, again, infection having various institutional protocol, we need to see whether that infection severity is life-threatening. If it is there, obviously we need to withhold the immunosuppression. If it is a severe sepsis with shock, we can think about CNI later on after a week or two. But obviously, we should not ideally restart MF again, considering the overall immunosuppression what we see. Again, with this type of situation with shock, we need to have stage dose steroid addition if needed. Now, with moderate infection, where hospitalization is needed, IV antibiotic is used, in that situation, we can hold antimetabolite for 4 to 6 weeks, and then we can restart maybe up to 50% of the dose. And if in that situation, if there is a recurrent infection, we should stop MMF permanently. Again, in some cases, we need to reduce the steroid considering if there are fungal infection. If there are community-acquired infection or mild infection, we generally don't need to change the maintenance immunosuppression otherwise, but we need to be cautious for the levels. We need to monitor closely, particularly elderly patients and patients with comorbidities. Now, as we discussed, why it is institutional protocol and why some portions are individualized? Because it is not the protocol that when the dose to be made half or to be discontinued, but it is all over net state of immunosuppression that guide us more. So how to be decided? It's obvious it's a clinical situation where type, dosage, and duration of the immunosuppression, what are the underlying diseases or comorbidities are with that patient is with retransplantation, presence of non-viable tissue like necrosis or due to gangrene or any other part, or is there any fluid collection within the body, any invasive devices are there, how the host factor, like we already discussed about the leukopenia, how other metabolic issues are there, concurrent other infection or immunomodulatory viruses are there or not. This all together defines the next state of immunosuppression, and as per that, we need to further define. There are certain infections like CMV disease. In generally CMV, we need to reduce the overall immunosuppression, and ideally we can stop MMF. We need to review the CMV PCR every 4 weekly. MMF generally we should not reintroduce unless the patient is at high risk for rejection, say for example transplantation. And if we are reintroducing MMF, we should use at the reduced dose rather. If the patient is having BKV associated nephropathy, again we need to reduce the MMF first, around 50% initially at least. If still no response is there, where we are supposed to check the BKV viral load frequently, then we need to stop MMF. If still no improvement, we can further review the CNI dose and reduce that 25 to 50%. And again, periodically BKV, PCVR to be checked and creatinine to be checked. And reintroduction is again individualized and need to review. For HIV patients, generally TAC MMF and steroid-based regimes are there, but MMF used to be used cautiously for drug interaction, because there are exhaustive list of drugs with HIV that to be utilized, and in that drug interaction matters a lot. If the patient is having HIV infection, obviously we are supposed to now use interferon-free DAS, direct-acting antiviral, and generally MMF we can continue otherwise, except for high-risk patient. But for HPV reaction, if there is a reactivation, we need to stop the MMF, because considering HPV reactivation like CMV suggests there is a net state of over immunosuppression. Obviously, we will start the antiviral therapy in the form of entecavir or tenofovir, and we need to adjust the MMF based on hepatic function severity of the reactivation later. And if we are continuing, we need to see that in low risk reactivations, we can see that. For post-transplant diarrhea as an infection, already Hegde sir has discussed a lot that how we can see the history part, and first of all we can stop MMF and can start anti-coated MMF and MPS, and how the dose reduction switch over to azathioprine or minimization of immunosuppression to be there is required with that. For the third part is related to pregnancy. For pregnancy, MMF is considered in US FDA is a category D drug. So it's a contraindicated. And again, there is having black box warning for embryo fetal toxicity. So what are the MMF embryopathy? That includes craniofacial, ear, ocular, cardiac, limb, and kidney and GU tract involvement. We can see there are so many things out of that: cleft lip, cap palate, microtia, anotia. They are the common ones that we observe, with some fatal part that involves the heart, like VSD, aortic arch anomaly, and renal agenesis, that would be there. So if any patient, particularly young female who is transplanted, ideally we need to review the immunosuppression part first. Ideally, we should delay the pregnancy for at least a year post-transplant, because that is the first year where the maximum chance of rejection would be there. Again, stabilization of immunosuppression is needed. So during that part, if you have stabilized the patient proper, in that situation later on we can withdraw the MF and can switch over to azathioprine. Again, we need to ensure the use of long-acting contraception meanwhile, so that she don't get pregnant. We need to educate them how MMF teratogenicity will affect the offspring. For planning, we need to stop the MMF at least 6 weeks before the conception. Then we need to switch to AZA first, and we need to continue tacrolimus and low-dose prednisolone that comes with the category C as per the US FDA. During pregnancy, we need to continue strictly we need to stop MF and ECP MPS as I safe and preferred. Again, we cannot use mTOR inhibitor. Post conception, we can see for if the conception is there with unplanned MF exposure, we need to immediately withdraw the MF, fetal animal scan and genetic counseling to be done, and we need to switch to AZA-based regime. That we are going, again, this part is really important. We'll discuss again in the later slide. For this, if you can see that we are stopping the MF immediately, but still considering the highest anomaly is there in the first trimester, we need to review that. For that, we need to see for fetal risk counseling. We need to see for any antenatal scan if any abnormalities are there with facial, ear, cardiac part, or having spontaneous abortion, because spontaneous abortion is significantly high with MMF. Now, for fetal assessment, we can have maternal fetal medicine specialist with us to for review that. Again, that review to be continued for first trimester or early second trimester anomaly scan. Again, fetal echocardiography to be included. There are consideration for non-invasive prenatal testing or further genetic counseling if any abnormalities are suspected. And as we discussed already previously, that the switch from MMF to azathioprine to be there, and meanwhile tech and steroid with the lower dose to be continued. For breastfeeding, if MMS is not recommended during the breastfeeding and after delivery, if we need to restart the MMF, it need to only restart after stopping the breastfeeding. Thank you.
That was a wonderfully nuanced discussion, sir. You have highlighted many practical aspects we often encounter in our daily practice. So the first panel question is for Devdutt Chafekar, sir. So what is your protocol of MMF dose adjustment in patients developing leukopenia? How do you decide between temporary cessation and dose reduction?
Yeah, so I think one slide was shown by Dr. Jigar regarding one algorithm which he showed how to go about it. However, I think he rightly said that this has to be individualized because there are no set guidelines. So how do you decide regarding what to do if there is neutropenia? So you go by the clinical picture, one. You also look at the other drugs which the patient is on. So most of the patients would be on valganciclovir for CMV. They will also be on Septran, that is trimethoprim sulfamethoxazole for the pneumocystis prophylaxis. Of course, there'll be immunosuppression, including tacrolimus. So, and of course, you also have to look at the induction agents. What induction was used? So that was ALG-ATG versus a basiliximab. And also remember that, as was already mentioned, that this is the balance between rejection and infection. So therefore, all these factors you have to consider and then take a call how much, what approach we need to take about the neutropenia. There is no consensus, but if I have to tell you a simple algorithm which can be followed, then what you can do is you can look at the leukopenia. How much is the leukopenia? So leukopenia is graded into various grades. So up to 3,000 is considered as okay, 2 to 3,000 and 1 to 2,000 is grade 1 and grade 2, and less than 1,000 is considered as severe leukopenia. Or you can look at the ANC, which is the absolute neutrophil count. And there's a formula to calculate the absolute neutrophil count. Less than 1,500 is considered as abnormal, and between 1,000 to 1,500 is mild, 500 to 999 is moderate, and less than 500 absolute neutrophil count is considered as severe. So now if you want to categorize these patients into an algorithm, so if your neutropenia is grade 1 to 2, by whatever definition I have told you, then, and the patient does not have any fever, and there is a neutropenia, then the recommendation could be that you reduce the dose by 50% of mycophenolate and continue the same medications and monitor. Or if you want to look at the ANC, absolute neutrophil count, if the drop in ANC by more is by less than 60%, then again reduce the dose by 50% and wait. If the drop in ANC is by more than 60%, then you have to be more careful about the MMF dose or reduce it further. As far as the other concomitant drugs are concerned, if the patient is on valganciclovir and if the patient is already 4 months down the line, then you can very well stop the valganciclovir. If the patient is less than 4 months, then what you could do is you can do a CMV PCR. If the CMV PCR is negative, then you can try stopping the valganciclovir and see whether the neutropenia recovers. And the third drug, which is trimethoprim sulfamethoxazole, again, if it is more than 3 months, you can stop the drug. If it is less than 3 months, then continue. If you have reduced the dose of mycophenolate by 50%, and if you feel that this is required, the drug is required, Then, as mentioned by Dr. Jigar, you can give GCSF or GMCSF to find out whether the neutrophil count improves. If the neutrophil count is less than 1000, then surely you have to give GCSF, because otherwise the patient will go into septicemia. So generally, this is the approach as far as the mycophenolate related neutropenia is concerned. And very rarely we need to stop it. But if you stop it, then obviously you have the choice to switch to everolimus or sirolimus and then continue with the immunosuppression. That is the way I think we can look at it.
Thank you very much, sir, for laying out such a balanced approach and helping us navigate this common dilemma. Second question is with Dr. Subos, sir. Sir, how do you manage immunosuppression in women of childbearing age who are on MMF and pregnancy planning? It has been discussed by Jigar, sir, but do you switch to azathioprine pre-conception or post-confirmation?
Okay, thank you, Saurabh. And Dr. Jigar has already, gone through the entirety of the topic in a very, great detail, and he has covered most of the topics. So I hardly have anything to say. But the first thing is to make it a planned pregnancy. It should not be that the patient jumps into your OPD with a bag of sweets and like, yes, I am pregnant. So that should never be the issue. That should never be the situation, and it's kind of a failure on our part. So I think we should always try to primarily seek out these patients who may actually plan for a pregnancy, to counsel them again and again about the various issues regarding pregnancy, especially the child and the malformations that the child can have on MMF. So we usually stop around, say, if the patient is planning, so we plan around 3 months to 4 months before the pregnancy, we plan to stop, change over to azathioprine. In all patients, we typically offer, in our setting, we offer to do a single antigen bead assay, but which may or may not be possible in every setting because of the cost and every availability issue. So once we are very sure that the patient is optimally immunosuppressed, because this leukopenia is also a very, very bad issue with azathioprine. Some patients do not tolerate azathioprine very well. So in the middle of a pregnancy, if all of this is happening, so we're kind of in a very bad situation. So we don't want to shift, then ascertain that the patient is tolerating tacrolimus MMF, all is fine. Have a few tacro levels, because tacro levels typically will fall once the pregnancy is there. And then that's the way to go. So by and large, we don't want to wait till a pregnancy has been conceived and then change. So it is always a pre-planned change from MMF to azathioprine, and then we go over to, and then we continue the pregnancy. Monitoring of the tacrolimus level is very important. Changing back to MMF is actually a very dilemmatic situation, because although Dr. Jigar said that MMF is typically not to be given during the breastfeeding, but there are actually some reports where they have shown that there is some little bit of increase. The evidence is actually bilateral, but there is some increase of the number of rejections because of the probably low immunosuppression and whatever. And second thing is, we have evidence to say that MMF is is a better drug compared to azathioprine. And that is when there is very little bit of MMF in the breast milk, and it may or may not have very much, very far-reaching effects on the child also. So maybe in the later part, if you're comfortable, we can actually go discuss with the patient and then change over to MMF even when the patient is breastfeeding. So I actually do consider. So we do have a few patients who are breastfeeding and on MMF, and that's what they are doing fine right now. But that's just anecdote. Thank you.
Thank you, sir. Your emphasis on pre-pregnancy counseling and risk stratification reflects the precision and empathy that is needed in transplant care in women. Thank you very much, sir. The third talk is by Dr. Binoy George David, sir, on recent advances. It includes the MPA monitoring and dose personalization. Over to you, sir.
Yeah, thank you. Thank you, Saurabh. Thank you, Manish. Thank you, the ISOT team. It's just some of the few slides that I've had over the last few years. I was called on Monday, so I was not so caught offhand, but I do have some information which I think will be very relevant for our day-to-day practice, and I'll just share a few slides that I have. Saurabh, can I just share the slide?
Yes, sir. You can share, sir.
Yeah, I'm doing it.
As a panelist. Yes, sir.
Can you see the slide?
Yes, sir. It's visible.
Yeah. So I bring you greetings from Christian Medical College, and this is our new institution that we moved in October 2022. So this is just some of the clinicians' perspectives of therapeutic drug monitoring and why it is important. And this was started in our institution about 20 years ago, or probably a little more. And I was fortunate to be part of that last 20 years to know and see how it is. Just to give you a brief outline, is really TDM needed? And what it has taught us over the 2 decades with regard to MMF and MMF-NA, and I'll just conclude with few points. So we should know the historical and the importance of TDM. The desired and the undesired effects of drugs are clinically judged for most of the drugs. Certain drugs and responses are unexpected in certain patients. So the concept of monitoring drug levels for risky drugs in patients at risk is very important. This is where the TDM concept came into clinical practice. Specific drug concentration, biological fluids, designated intervals in a single or a multiple time points of estimation that we may need. And with that, can we maintain a constant concentration of patient's bloodstream and thereby optimize pharmacotherapy? When we look at the historical background, 1960s, the TDM was introduced. It initially started with epileptic patients and then it for lithium. And then it progressed in 1970 to focus specifically on adverse drug reactions and reduce the incident of toxicity, thereby determining and ensuring therapeutic ranges. When it came to solid organ transplant, I still feel, and the world has changed, it has become the cornerstone for one of the transplantation programs. It helps in maintaining the function of the grafts, guiding therapy, individualization in the drug dosage for every individual that comes to have, and we can have a predefined target range. So it has been routinely performed in calcineurin, mTOR, and mycophenolate usage. Besides that, in transplant, patients on antibiotics, their dosings and things can be done. So all this importance came into these three, what I would say, the consensus report that came over, started in 2016, 2019, and 2021 in talking about everolimus, tacrolimus, and mycophenolate. And they establish optimal TDM practices for these agents. So when we look at the review of literature, they looked at all these 4 points. And in today's TDM, we can really look at the patient compliance, drug efficacy, drug interactions. We should be aware of the drug-food interactions, individual variation in cure response and toxic effects, and also when to cessate the therapy. It also told these consensus report they assess the clinical benefits of TDM in prospective randomized manner, not in observational cohorts or retrospective, giving a good correlation between the risk of rejection and the drug toxicity. This report also, these reports, they talked about the therapeutic window in which you can provide maximum therapeutic concentration with minimum toxic concentration. So is it really needed? And is it really good for a therapeutic effect? Drug toxicities, remember, we have ethnic differences within the country, leave alone the West or the East, that we are trying to do with us. Simple reason, my absorption of a drug is different from an individual in this panel or a person or from another patient. My pharmacokinetics of my body is different and my pharmacodynamics is different. So why all this concept came in was, if you look at the history, post 1980s of 1 year graft survival improved. Kidney was about 88 to 93% and so on for the other organs. But having said that, the toxicities increased. Adjuncts were used trying to reduce or increase the levels. So it was a real challenge when we were looking at the reality of the immunosuppressive drugs. Hence, the concept of personalized or precision medicine came in. They looked into pharmacokinetic variables, looking at trying to do the genomics, the pharmacogenetic, looking at pharmacodynamics, like trying to achieve drug-specific target concentration. Then they try to combine these to see whether we can have models. And I'll just take you down through what was done in MPA and to see whether these things were applied in tacrolimus as well. So when I look at the journey that I, as a registrar, was exposed with my teacher, Dr. George T. John, and till today, it has been a big, fantastic experience as a clinician. When you look at MPA in the last 2 decades, if we do look at the 2 molecules as the entry-coated and the mycophenolate plain, it's all was fixed dose were recommended by the manufacturer. It was increasing the awareness of a personalized dosing of this drug, especially came in stem cell transplantation and with the off-lobe indications where MPA was being increasingly used, for example, SLE. Now, and in some cases now IG as well. So many other cases. So the TDM perspective came of measurement of drug concentration in the plasma or serum, which is the most obvious method, and try not just for practice it in centers just for MPA, but also look at antibiotics, antiepileptics, and now here we have started even looking at anti-tubercular drugs, especially for rifampicin, is something that we are looking into. So the early 1990s, this was the role it came, the reduction in acute rejection, and when compared to azathioprine and FDA approved in 1995. Remember, azathioprine, I still feel is a very good drug. It lost its role in immunosuppression because of the tolerability of how patients can take care of ASA, and that's how MPA took its role. We have gone through the mechanisms of action, but just to highlight to all my physicians listening to me today is the pharmacokinetics of MPA is really complicated. They have a very non-linear absorption. They have an enterohepatic circulation. They have a very good plasma protein binding. Hypoalbuminic patients going in, coming out of transplant, low albumin affects the levels. There is a lot of genetics at play, and something that is we need to understand in our pre-transplant and post-transplant counseling, how the drug-to-drug interaction, education of the patient, empowering simple fruits is very, very important. We all say grapefruit, and we think it is actually the grapes. It's not the grapes. It's another grapefruit, which is a large kind of a citrus fruit, the star fruits, the dragon fruits. These are all things that can influence the tacrolimus levels, antibiotics. So this is how it's complicated, the pharmacokinetics. And when you're looking at complication, it is basically it's because of the enzyme. It is metabolized in the GI, liver, and the kidney. And the major metabolite is the 7-MPA, highly protein bound, which can remain in the system, causing you, as all highlighted by Dr. Umapati and Dr. Jigar, of the side effects, leukopenia, GI disturbances. And this metabolite is actively secreted in the urine. So when you're approaching towards a graft failure and things like that, you need to understand whether this kind of a dosing or fixed dosing is really needed for an individual. And it has very minimal elimination in the bile. This I've highlighted again. The PK features tell us that the drug-drug and gene interaction, extensive enterohepatic recirculation happens as the second peak. This is why it is a very tedious test to do for 6 hours for patient to sit. Please remember abroad, like in US or in the unit that I worked for my study leave, they don't do the tedium. Simple reason, only our patients will sit for 6 hours, take a samples every hour, 1 hour, 2 hours, and 6 hours. Because I'll tell you why the difference it makes and why the patients come back. I'll show you some data that we have. The absorption characteristics differ significantly between the two molecules. And minimizing the interchangeability of TDP approach, like having a limited sampling, is the only way out. So this is one of the first papers that came out did by from our side by Binu, Dr. Binu Matthew, who looked at it, where a single time point measurement have not proven sufficiently informative in prediction of patient outcomes. Hence, the limited sampling strategies we started, and we developed an AUC curve that was successful in terms of correlation with outcome and identification of therapeutic ranges. So the early use, everywhere there is a fixed dose that is used, 2 grams in divided doses. Heart and liver have their own dosing. Concomitant use with CS, cyclosporin TAC, and sodium, adults 900 milligrams per meter square in 2 divided doses, or in pediatric kidney transplant, it was going again 1,200. The fixed dosing, something that was not reported, was the underexposure of the drug on most of the literature that we look into. This is where 4 key prospective studies brought out the evidence of looking into TDM guided dosing and the target reference ranges. And I have listed out these 4 trials, which was actually alluded by Dr. Umapati as well. And these are the 4 important. It's very good as a trainee to go through these studies and understand the concept of fixed dosing and an AUC, and you can understand the difference. Then the conclusions, I'll just say from all the 4 studies, I've just summarized it for time period. The target MPU AUC for a 12-hour monitor is about 30 to 60 is what is recommended. Here in Vellore, we maintain to about, we don't even reach till 60. We keep it around 35 to 40. There is no evidence of a specific AUC 12-hour targets beyond the first year after transplantation. These are the studies effect. No exposure effect, nor concentration control study of the enterocortic MPA has been reported either in adults or in pediatric kidney transplant. And there's no evidence in favor of using MPA, that is the C0, to a dose-adjusted MMF for the MMF or the enterocortic MPA sodium. Now, the unit that I worked in Adelaide, we were using MPA Z0 to adjust the dose. Remember, the absorption and the second peak enterohepatic circulation can give you a significant difference in the C0, which is usually maintained between 0 to 4. So in Vellore, what we did is my teacher brought this along, George T brought it along with Binu. It was a trial and error method, and we learned it in a very, very hard way. We decided we will go with milligram per kg dosing in MPA in CMC. We learned over time. And I thank all my teachers who have been here and my colleagues who have actually helped us to regularize this, because we learned every time. We used to start doing every dose reduction. We were doing monthly, significant financial burden over time. But today we have come down to do it only on either day 5 or day 7 post-transplant, first month, third month, 6th month, and then annually. That is what we have come. We don't even repeat a dose, a AUC level after we dose reduction, because we have understood the pharmacokinetics. We have evidence with clinical outcome. I will show you. The simple reason is one size does not fit all. Please remember what the milligram per kg of tablet that you start in the transplant, which might be 1000 milligrams BD, has come down, or what we have started 750 milligrams in a milligram per kg tablet. By the 3rd month or 6th month or 1 year, we are down to 250. Significant reduction of cost per month. Reduces the infection, keeping rejections at bay. And this is the kind of dosing that we do for MMF and MMF sodium molecule. This is what we have learned. Please try to look at the yellow bar represents the AUC is done at less than 1 month. And you have the x-axis says the AUC range, and this is the number of patients that have been done on the y-axis. So the yellow bar is the one that we have done in less than 1 month. 1 to 3rd month is the red bar, the 3 to 6 months is the blue bar, and more than 6 months is the green bar. You see that the absorption of the drugs is very poor in the less than 1 month. Very simple reason is the uremic milieu, the hypoalbuminemia. Once the graft function improves, the uremic milieu subsides, the albumin improves, the absorption of the drugs is better, the AUCs get better, you can come back, cut down on your dosing schedules. So what you start with the costing from the beginning in the 1 month has reduced by the 3rd month, and it just significantly improves as we go, and we come to the very minimal dose by around the 1 year or post 1 year. Look at this for those who did not do an AUC and for those who did a AUC. We compared both, and we actually normalized it to 35 milligram per kg, and you'll realize the absorption significantly gets better over a period of time, kind of stabilizes after the 3rd and 6th months. Very few drop a level, but it has not caused an effect. So to answer a few questions, we looked at this, the renal transplant with rejections and infection outcome with mycophenolic acid therapeutic drug done by Swati Mane. She's currently in Pune. She's doing quite well. So this was a observation study that we did, a retrospective. We looked at the AUCs. This was a inclusion exclusion criteria. This was the kind of immunosuppression profile that we're using. Majority of them we use pesliximab as an induction. Only the high-risk individuals we go for the T-cell depleting T-cell depleting induction. And the MPU AUCs, when we looked, were done in varied fold, 23, 15, 16-fold between patients on day 7, month 3, and 12 months respectively. And the following, the table below shows the values below and above the recommended targets. And what you see is by around the day 7, only 19% of them actually achieve the level. whereas by day 12, it is only about 15%. But one thing that you can see is by about the third month, the absorption gets better. Look at the graph with the standard error that is seen. Very low levels in week 1. By month, it goes up because we increase the dose. Obviously, within the first early months, we face the leukopenia. We then reduce the dose, and then it kind of stabilizes at 1 month and 3 months at this particular level at 40, 42. When we look at this one at different time points that you see when related to the MPA dose trends in recipients, you can see by the 6 month, the dose requirement comes very low. So this is what we have learned over time. When we look at rejections, definitely at day 7, low levels did predict early rejections. And this was biopsy proven. That is 17 out of the 43 that we had shown. And they were associated with levels of less than 30. When we look at the overall AUC kind of graph, the average value that you probably would need to maintain this level is about 40.9. So that is why we keep a level between 30 to 35 to 45 is what we try to do. When we look at the 6 month, we see the absorption has significantly improved when compared to day 7 and day 3. We are going overboard. You might face the first 3 months of leukopenia. Always, I feel the culprit of leukopenia in the early transplant is MPA. So we don't do a level to see if it is really high. So what we do is we just go directly reduce the dose to about 50%, keep the infective prophylaxis going, because the bone marrow suppressive effect of MPA is significantly it definitely gets additive with Septran and Valgan, as the speakers have mentioned. But if you take off the MPA or you reduce it by 50%, you can circumvent the leukopenia. But agreed, as if you go below that neutropenic one, we'll have to pull out both. Or you can earlier start, you can actually, the Valg dosing and Septran, you keep it alternate day, you can even still circumvent it as well. So the toxicity, when we looked at exposure at 3 months, when compared to those who were infection-free, it was significantly higher in recipients who had infection in the first 3 months, the higher levels. That was around 59.45, plus minus 21. The difference was not statistically significant at the time at first year. So the higher MPA exposure was definitely has an increased risk for leukopenia, which is known by all, even if when centers who don't do it and centers who do it as well. But the reason is the pharmacokinetics is different. So the study just concluded the importance of achieving an early target exposure and also finding an association of low early exposure to MPA and acute rejection. So it can be, and it should be practiced that AUC can be a biomarker for drug exposure. So looking at the further advancements of looking at IMPDH2 levels and trying to look at the genomics of doing drug transfer of the ABCC2 variants, looking at how the metabolization, there are now reports of resistance to the metabolizing enzymes. The shortcoming is that these literatures don't mention if it was a fixed dose or a TDM guided MPA approach. So this is something that when you're trying to look at IMPDH2 levels, it is a very technically difficult procedure to be done in a lab. We tried it and it was very difficult to do it. So we actually kind of left it going. Now, the PK, that is a pharmacokinetics, a pharmacodynamic variability of MPA, can be explained by pharmacogenetic variation. But the data that we have today is inconclusive, inconsistent, and there are conflicting. The reason is the effect of genetics on MPA, MK seems to be limited. We have different cohorts which cannot be compared to each other. The Western cohort cannot be compared to us. The other variables, which actually affect was not looked into or not considered as important. For example, the calcineurin therapy, the cyclosporin. You increase cyclosporin dose, you can reduce the MPA dose automatically comes down. So this is how it helps in TDM as well. So if you're doing a cyclosporin, you know if there is a very high level of, you get a report of a very high cyclosporin. When you reduce the cyclosporin dose, please understand the MPA level is going to go up. So that is the benefit of doing TDM. Now, concerning the effect of the genetic variation of the pharmacodynamics, there is subject variability. Again, data is very convoluting. So currently the use of pharmacogenetics to personalize MPA treatment seems to have no added value to TDM. And a preemptive genotype-based dose adaptation is currently not recommended. So the importance of step for a thorough PK and pharmacokinetics and a pharmacodynamic investigation should include very large numbers. When you're doing measurements of IMPDH activity, the peripheral blood monocyte, that is what is required for MPA monitoring. You should remember there are two types of isoforms, and MPA has a fivefold inhibitory affinity for the type 2. So the new insights into the mechanism of action MPA should be actually got from the direct pharmacodynamic assay. So it has been used definitely in pediatric cohorts, several clinical studies, and based on a higher technology of technical activity. So before clinical care is altered based on IMPDH monitoring, my request is, or my impression or my reading is, more data is needed to establish a relationship. The post-transplant course of IMPDH activity should be just monitored and see what's happening before you base your decision on dose reduction or increase. The causes between subject of IMPDH variability and association should be known with clinical outcomes. And can we achieve same target therapeutic ranges with IMPDH inhibition is something that needs to be looked into. So how can you actually, there's a very good paper that came out recently, if you really want to look at the future. Approach for predicting the variable PK is to combine population pharmacokinetic analysis. It is called the POP-PK analysis. It's a very good article that this has come out. It's good for reading as well. But to summarize after reading, the challenges in this kind of a model is the pharmacokinetics of MP is highly variable. Secondary peaks of various intensities appear at variable time after dosing. These phenomena can lead to a complex absorption profile. So you need actually more and more of clinical data with pharmacokinetics and pharmacodynamics, that is pharmacogenomics and pharmacodynamics, with the pharmacokinetics that is doing. That is, you do your TDM, be blinded, do the genomics, and see how the pharmacodynamics, that is the delivery of the drug, how does it affect. So there is still much to learn in this field, and there is a lot of opportunity. So optimal references is the need of the hour, for different patient cohorts, varying immunosuppressant combinations, how to best perform dose adjustment on exposure measurements and patient response. The sources for pharmacokinetic variability of immunosuppression is something that we need to look at. We need to look at other novel mediums. For example, tacrolimus. Can we do a dry spot saliva test? It is very well secreted in the saliva. Can we do an IMPDH cell? Can we isolate? These are techniques that we need to look over drug exposure immune. So how to influence the patient behavior? Ensure adherence. Remember, when we are reducing the drugs, when we do not know if they are underexposed, you are actually triggering a subclinical donor-specific antibodies, which are not monitored or which is difficult to do. I understand it's not there, but when we are reducing immunosuppressions, we need to keep these things in mind so that we can give them a safe transplant and a very good post-transplant period. Immunosuppression medicines, ongoing development. We should look at personalizing medicines, and the clinician's aim should be to improve long-term outcome by combining new standard PK approaches, pharmacokinetic with pharmacogenomics, have a very valid biomarkers. So grading has usually been recommended. Use of the variables has also been recommended, but we have not been able to do that because of long-term lack of studies. So finally, to conclude, continuing efforts should focus on the opportunities to implement in clinical routine the combination of various approaches. Yes, in an academic cohort, it's difficult to do with the research, but then these are ways that we can try to do. And I really like to acknowledge my teacher, George T. John, a wonderful team that we have, that we still have by today. We have been blessed with it. And there is another gentleman whose name has come as Dr. Blessed, the lab person and above all, our patient. George T. was an astute physician, motivator, mentor, dreams only of transplant. He sowed the seeds for TDM for us in CMC Velo because he was foresighted, visionary, and research was his passion. Till then, I always request all to practice medicine wisely and honestly. Thank you.
Thank you very much, sir, for this forward-looking presentation. These invaluable recent updates that you have shared, they will certainly shape how we manage our transplant patients. Now for panel discussion, the first question is for Urmila ma'am. Ma'am, what is your view on using pharmacogenomic markers or personalized immunosuppression algorithms for MPA dose optimization in Indian transplant recipients? The sir has shared many points in his presentation also. So what's your view, ma'am?
Thank you, Saurabh, for this opportunity. And it was a pleasure to hearing one of my own alumni talk about TDM. And I would, on a personal note, like to remember Professor George T. John, who is in Australia now. I'm actually in Vellore because of him. And one day I'll share an anecdote how I got into Vellore because of him. That's later. Now, after Binoy's talk, I think there is a lot of clarity that if it was so important to have a person, it is important to have personalized MPA dosing. There is no doubt about this because this is one of the most difficult drugs that we handle in transplant. And what we do is we do a fixed dose and we say, ki, let's say 720 milligrams of MPS BD and leave it at that. And later, in a later part of the transplant and year 2 or 3, we said, don't bring it down. Don't bring down tacrolimus, don't bring down MPA. You create de novo antibodies, you do a lot of DSAs and you do a lot of harm. But that is, I think, not the truth, and that is the right thing to do. We like tacrolimus, we also should try to have some kind of an indication what we are doing with MPA. As Vinay has said, the pharmacokinetic variation of MPA is almost tenfold in patients. Not just ethnicity, not just enterohepatic circulation, not just absorption, not just mutations in, let's say, UDP, glucosidonyl transferase 1, or in the transporter proteins like ACBC and all those things, ABCB, C1, 2, and all those things, and then also even INPDH 1 and 2. But the problem, as he said, if you look into his first slide, what are the things that monitor or modify mycophenolate level? Genetics just forms a very small part, very small part. And if you're going to look into pharmacogenomics to decide on dosing, it will be difficult in our patients. And we have to have data of our own. There's a very good scoping review which you can look into all these mutations in mycophenolate. There are hundreds of studies, but how many patients? 35, 40, and very, very, very contradictory results. In Chinese, it is different. The same mutation which increases MPA exposure is actually less in others. Some of them are because of the upregulation of the transporter proteins. Some of the urate transporters, we didn't discuss organic acid transporters in liver, they get upregulated. So your exposure increases. But if you have another drug like cyclosporin or TAC, that modifies its metabolism. So in short, it would be very useful to use it. Maybe a group of patients who are leukopenic or having adverse events in very low doses, find out why they are having like this, or patients who do not achieve the AUC that is required with the standard dosing. So first you need a AUC, and then you can go down to your pharmacogenetics and your studies. Thank you.
Thank you, ma'am. That's much a needed take. And precision medicine is not just for oncology anymore. And yours and Binoy sir's points add near necessary realism to this discussion.
But
Second
I think
question
we
is for
should do AUC.
yes, ma'am.
We should do
Yes, ma'am.
AUC. And what Vinay should have said, see, if you're using MPS, I mean sodium, the absorption in the gut starts 2 to 3 hours later. So when you do the AUC, you should be clear ki what levels are we going to check. Is it C0 or at C3? I mean, at third hour or fourth hour. And some of these levels, not just 6, you may need to go till 12 hours. If they have a higher level of acyl MPAG, that is mycophenolate glucuronide, those are also effective drugs. So there is much more to learn on this.
True, ma'am. The second question is for Dr. Lavdeep. So in the context of limited access to AUC monitoring in India in most of the hospitals, how do you clinically assess the under or over immunosuppression in patients on MMF, especially in the borderline cases?
Good evening, sir. Thank you for including me into this wonderful presentation. And I essentially, this question is very well portrayed over here that while we do not have access to AUC for MPS or MMF, in most of the clinical circumstances, at least in our state, and transplants do happen very often. So there is actually the clinical judgment, I believe, which makes the difference for such patients. Establishing the right balance between immunosuppression while reducing opportunistic infections and as well as reducing rejections is the key. I personally feel is important to handle such patients. While we have patients very commonly presenting to us with different opportunistic infection, fungal infections, as well as UTIs, recurrent UTIs also. In such patients, we believe in tapering down MMF levels pretty early. We have come up, we recently submitted one paper into the ISOT also, wherein we had one patient with nocardiosis who had for which who just 4 months after transplant, and then we had to dramatically reduce the dose of transplant immunosuppression for him. Now such patients obviously require reduced doses of immunosuppression for which we do not have any method to calculate for. He was on TAC monitoring, but sadly we do not monitor MMF levels in our day-to-day practice. We don't have the tools, neither are we rightly trained to check for such levels at all setups. Now, having said that, in this patient, the transplant, once we reduced immunosuppression, now almost a year after this also, after reduced immunosuppression levels also, he's doing pretty fine with an creatinine hovering around 1.1 to 1.2, which is pretty good for all matters. We want the patient to survive more than the graft. And such coming down on these medicines on immunosuppression, we should not be, that's not the time to have to develop chicken feet when the patient is, the life is in danger. In the previous presentation also, it was said that patient who develops recurrent infections, recurrent life-threatening infections, recurrent infections with more than moderate or severe infections, we tend to either stop or switch from MMF. In any patients with acute infection, obviously, yes, we do consider reducing the doses and discontinuing MMF if the patient develops a life-threatening infection. And then coming next, in patients who develop leukopenia also, we tend to reduce dosage of MMF as compared to tacrolimus, because usually our patients, while on steroids, should have higher leukocyte counts, and leukopenia is a known side effect of MMF. Though I'm not very sure what we should be doing about MMF when it comes to GI side effects. Though, yes, we do reduce the dose, we change to entry-coated medicines, we do reduce the doses also. But I'm not sure how does it impact the graft outcomes in the long run. For that, I am not very sure. Eventually tapering at 1 year, 2 years, and as Madam also said, eventually tapering transplantation medicines at 1 year, 2 year, and 3 year is said to be conventional, but then that's not personalized. That's not personalized. It's more of a convention, I believe.
Very practical point. A great reminder that while technology is welcome, clinical acumen remains irreplaceable. So, any other question or any other discussion we can have in next 2-3 minutes?
Dr. Saurabh, I think there are a few questions in the Q&A, so maybe you want to take that.
Yes. So first question is, I think for Binoy sir. Some anonymous attendee is asking, sir, were not FDCC and OptiCept the two largest trials, were the negative trials and didn't show any benefit? Rejection was same and drug levels were same. If yes, then what is the evidence currently supporting TDM?
So the rejections and the drug levels were the same, but we should look at it our context. We are not just only trying to prevent rejections. Our context is that our patients die of infections. Our patients don't have money to buy medicines for long term. So that is why I keep saying, we all keep saying that we should do it in our study to see how TDM benefits us. We are only worried about trying to make sure there's no rejections in the first year. And then after that, we don't have a follow-up. So here the TDM, the benefit is reducing the cause, preventing the infections, but having adequate levels to prevent further rejection. So yes, so that's a trial that is done abroad. Then we should be doing that the same. So that is what our study that we continue to do. I hope I was able to answer the question.
Thank you, sir. One more question by Dr. Payal. Considering the delayed absorption seen with MMF sodium, can limited sampling strategy for 6 hours only and same target levels as that MMF be applied to MMF sodium?
Please, could you just repeat the question, Saurabh, again?
Sir, Dr. Payal is asking, considering the delayed absorption seen with MMF sodium, she's asking whether the limited sampling strategy of 6 hours only and same target levels as that of MMF, that should be applied to MMF sodium also, or we should have some separate?
You cannot. We have kept the same levels, but this limited strategy sampling is actually for the lab. So some of the people, their absorptions, for example, I know of a sodium molecule when compared to another sodium molecule, we have extended to 8 hours because their absorption is different. So you cannot reflect. This is basically done for the sampling for the lab to do. We can maintain the same level, 30 to 60, but your dosing, knowing that they will require a higher requirement for an MMF to achieve a level, we tend to dose it a little more. That is why.
Thank you, sir. Any other questions from the panelists? Any other discussion? So I think that is it. And it was a wonderful presentation by the speakers and wonderful discussion by the panelists. So on behalf of ISOT EduConnect, I extend heartfelt thanks to all our distinguished speakers and panelists for their valuable time and insights. Your perspectives have enriched our understanding, and it will surely reflect in better transplant care across the country. A big thank you to our participants as well. Stay tuned for the next session in this bi-weekly series.
Thank you. Thank you.
Thank you very
sir.
much.
Thank you, ma'am.
Thank you, Dr. Saurabh.
Thank you. Thank you.
Thank you, ma'am. Thank you, everyone.